Hello, I'm Jeremy Clark, Market Chief Executive Officer at Hilton Head Hospital, and I'd like to welcome you to another edition of our show, Healthy Living. We use this show to highlight the physicians, programs, and services that we offer to help you live a happier and healthy life. We are very proud to have been delivering extraordinary care right here at home for over 40 years. And so, on behalf of the physicians, colleagues, and volunteers at Hilton Head Hospital, I want to thank you for watching, and I hope you enjoy the show.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
No one likes to wait, especially in any ER waiting room. I mean, when I'm sick or my family has a medical issue, I don't feel like waiting around with a lot of other people. Not to mention they're sick too. Honey. And my family does not wait patiently. You can imagine how uncomfortable and how long it can seem. But then I found out it doesn't have to be that way. I can check in online and wait anywhere I want. What's not to love?
It's the smarter way to ER at Hilton Head Hospital.
Hi and welcome to Healthy Living. I'm Dr. Debbie Lanes. I am here with Dr. David Castle, and we are talking about things that are very interesting. One of the things that you are known for is really the arterial system, and Hilton Head Hospital is known for their incredible screenings. Can you talk to us a little bit about the screenings that you have coming up and how often you have them?
Well, Hilton Head Hospital sponsors about 4 screenings a year, and these are free to the public to come in to have their peripheral vascular systems checked.
And I think one of the questions for me is for you to describe what a peripheral vascular system is, and then what a screening would actually be like for a patient who goes in.
Well, the peripheral vascular system is the vascular system not related to the heart. So we're not looking for heart problems or heart issues or even going to talk about the heart. We're talking about mainly the carotid arteries, the ones that are in the neck,
okay,
which are in this area.
Okay.
They go directly to the brain. And we're at about the abdominal aorta between the kidney arteries and the branching of the arteries to the legs. People can have aneurysms that need to be detected before they rupture in these areas so that they don't become symptomatic.
One of the things as we're preparing to talk about this is that most of these are asymptomatic, and that's why screenings are so important. Can you elaborate on that?
Well, blockage of the arteries is caused by plaques, and they slowly build up. And because they're building up slowly, nobody knows they're really happening to them until they become symptomatic. And that's bad news, because if they're asymptomatic, you don't know you have them until you have a symptom. The symptom for a carotid artery is a stroke. And the symptoms for an abdominal aortic aneurysm is rupture, which is almost a surety for death.
It's very interesting. Who do you recommend comes out for the screening?
Well, anyone who has a history for any of these problems needs to be checked. Anybody who has
has a history. Okay,
maybe a family history, not that it's totally related, but there's reasons for these things happening. Most of them are environmental things, like what you're eating, if you're smoking, if you have high blood pressure, that type of thing.
Yeah, that surprised me when you said lifestyle.
So it's a lifestyle issue more than it's a hereditary problem for peripheral vascular disease.
What about age? Is age a factor? If I'm, my race, my age, my gender, any of those things specifically make me more likely to come to the screening, or it be a really important screening for me to attend?
Well, that's a good question.
Yeah.
What's happening is that the plaque is building up slowly, so it takes years for this to happen. It's not like we're going to find this in a 25-year-old person.
Okay.
If we do, it's incredibly fast, and that's an abnormality. But most people with carotid artery stenosis that need something done about it are in their 60s, 70s, or 80s.
Okay. Go ahead.
And as far as an abdominal aortic aneurysm is concerned, it's related to age factor, maybe 55 to 80.
Mm-hmm. And then, so again, you're talking a lot about lifestyle here. Asking you the tough questions again. If I'm overweight, or I don't exercise, or I'm sedentary, does that contribute to me coming out for the screening also?
Well, overweight is an issue because you're causing, or the overweightness is related to having inflammatory responses to the body.
Okay.
Anything that's inflammatory to the lining of the arteries is going to cause these plaques to build up. Mm-hmm. High blood pressure is one. It's an irritative force to have a lot of pressure going through your arteries. One is smoking. Nicotine going through your vessels is like a mild acid, mm-hmm. trying to scar them down. Eating a high diet in sugar mm-hmm. is bad because it's an irritant. Also, it's an inflammatory irritant to the lining of the arteries. And just processed foods in general, the chemicals that go into processed foods are very inflammatory to the arterial system.
We're going to talk just for a few more minutes about the screenings and get to some of the specific systems and talk a little bit more about that. You've got a lot of things to really share with us. One of the things that I wonder about the screening is how much time should I allow for the screening, and what is the difference between, is a screening simply to make me aware and then I am treated? What's the purpose, I guess, of it?
Well, the purpose is to find these problems before they become symptomatic, number one.
Got it.
Number two, as far as going to the screening, we usually take them on a notice of given a time. You call in, you get a time.
Got it.
You come in. That way you don't have to wait. Your
Okay.
time is at, say, at 9:30, you're at 9:30. It takes about maybe 15 minutes to go through the whole process. Mm-hmm. We have nurses that do the checking. We have somebody else that does the sonography, and then I review the process at the end mm-hmm. to make sure that everything was covered and everything is explained.
I'll tell you what people may not realize is that to do a screening like this is a huge advantage for our community. I mean, it's a pretty powerful thing to do.
Well, it's a way of returning some of the love, I guess, back to the community in the sense that we're making sure that people stay as healthy as they can. It's prophylactic mm-hmm. in that sense and preventative.
And I know we're going to talk about these systems, but I have to backtrack for a second and say this. I think you are one of the icons of the hospital, and I would love for a moment to just have you share a little bit with maybe the one person who doesn't know your background yet. Tell us a little bit about your history.
Where do I start?
Take me from your adulthood.
Well,
where'd you do your training in?
I went to medical school at the University of Oklahoma.
Okay.
I spent 2 years at the NIH in their cardiac surgery there in research. Did a general surgery residency at the University of Oklahoma. Mm-hmm. Did my training in thoracic and heart surgery in Pennsylvania. And from that point, I was in New Orleans for about 25 years until Katrina came and said bye-bye.
Mm-hmm. And then here.
And I'm here.
And I think the reason I really like to pitch you for this is that oftentimes communities have a feeling of saying, oh, the experts are over next door. But oh my gosh, you are here, and I think it's a real gift for the hospital and for our community.
Well, we do state-of-the-art evaluations for vascular screenings. We do state-of-the-art analysis for the, if you do, that's something we didn't talk about. If you come into the screening, we're not doing a very thorough examination, we're just doing screening.
Okay.
So if something shows up that's abnormal, then we need to do the thorough examination and evaluation, which takes a little bit more time and effort. But we have all the processes to do that and to decide what, if anything, needs to be done, and we can take care of it from there as well.
And that's the whole point of that screening, and that's the point I think you want to get across more than anything, is if this is silent and it's insidious, what a gift to be able to kind of nip it in the bud, if you will, because it's not something that you ordinarily would, palpitate yourself and say, ooh, I don't feel good. Let's talk, if we will, can we talk about some of the actual body systems and start out with maybe a carotid artery, talk a little bit about plaque and some of the things?
Sure.
Okay.
Well, we have this little piece of paper here mm-hmm. that shows the carotid arteries. And this is a carotid artery coming up the neck, and right about the level of the jawbone, it splits and it gives off a big branch to the facial muscles of the face. The rest of it goes on up to the brain. This diagram is showing plaque inside the artery here blocking the flow.
And what is plaque? It is a buildup of?
Cholesterol.
Okay. Okay.
But it started from inflammation.
Okay.
Not from the cholesterol itself. And anyway, this can get progressively larger, therefore progressively blocking the flow more. We don't worry about these plaques until they become around 70%
All right.
obstruction.
And again, I appreciate you helping me as a layperson understand this. The carotid artery's purpose is to?
Feed the brain.
Okay. See, I love it because you make it user friendly. You help me understand exactly what's going on and why it's so important. So if it feeds the brain and it's clogged, then I'm not going to get.
Well, like I said, we don't worry about these plaques. We watch them under 70%, but once they get to around 70%, then we start worrying about the issues of stroke, because the chances of stroke gets higher and higher as it gets tighter and tighter. So this is when we need to make sure we know at what level they are as far as obstruction is concerned. And at that time, we'll make the recommendation how to get this cleaned out.
Do most people have plaque that accumulates in a bilateral fashion, or do you often find it on one side or the other? And
It's all individual.
Okay.
It's some people have it bilateral, some people just have it one side, and sometimes they get it critically tied on both sides.
And can this plaque accumulate not only in the carotid artery, but in the other arterial areas?
Well, that's what we're talking about.
Okay.
We're looking for blockage like in the legs or the carotid arteries. The aorta and the abdomen is more of a dilation or expanding problem where it tends to want to rupture when it gets too big.
We're going to take a quick break, and we're going to come back and we're going to go more into detail. So stay with us. We'll be right back. Once again, we're talking with Dr. David Castle.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hilton Head Hospital.
We are back with Dr. David Castle. Thank you for joining us again. We're talking about some of the screenings that you do for the arterial system here at Hilton Head Hospital. We've been talking a little bit about what screenings are, why they're necessary, what they do and don't do, and who should have them. We're getting a little bit more in depth now about plaque, buildup, strokes, what they are. Take us from there.
Well, maybe we can take this,
this
little prop here. This shows an artery that's totally normal. It shows the lining of the arteries on the inside, but there's nothing in there except blood flowing.
Okay.
Slowly, through a process, you start seeing a plaque build up in the bottom of this one here that's showing that there's some obstruction started.
Is there a timeline that's consistent for everyone, or it just depends on who you are, how much plaque you have?
Well, it's a lifestyle issue.
You keep telling me that, and I keep waiting for something better, but that's it, isn't it? Okay.
And then as time goes by, the actual lumen or the opening for the artery gets smaller and smaller because it's being choked off by the plaque.
And that means that whatever it is feeding, whatever this artery is feeding, is getting less and less of the nutrients or the food? Or
That's right.
Let me make sure I put this back correct. Okay. And then stroke is the word that you used. Talk to me about what stroke is and isn't.
Well, if we can go back to this diagram,
please.
The second pane shows the plaque again, but inside this blockage here is clot that's building up because the blood flow in here is slowing down when it gets really tight, or clots can form on the plaque, but there's nothing to hold on to so they can get brushed out. And this particular artery is feeding the brain, so this is where these clots are going.
Oh.
In addition, pieces of the plaque could also break off and cause the same type of problem.
You know, we talk, it's again, once this plaque or this clot breaks off, that is what causes the stroke?
Yes.
Okay. And a stroke is when the clot goes to the brain?
Well, it's called an embolus.
Okay.
Anything that embolizes to the brain is going to cause what we call an infarct or a stroke to the brain tissue. It's going to deprive it of its circulation. Therefore, that piece of the brain isn't going to work, and people get paralyzed, or wherever section of the brain that's involved in is not going to work. Therefore, that's what's not going to work in the body.
Symptomatic at this point, obviously.
Yes.
Get into the hospital ASAP.
Well, that horse is out of the barn and down the road.
Okay.
What we're trying to do is prevent that stroke from happening. Mm-hmm. That's when we do the screenings to see if we got blockages, and if we do, make an assessment of how tight that is.
And that makes perfect sense to me. So we've talked about the carotid artery as one area that's going to be looked at in this screening.
Yes.
Second area that's going to be looked at in this screening, you said, is significant also.
Well, what we're looking for is the abdominal aorta. Again, like we talked about before, this is the abdominal aorta. This is the takeoff of the kidney arteries. This is the takeoff of the leg branches.
And the aortic
this is
artery,
the
aorta, feeds what?
The legs at this point.
Got it.
But it's feeding this is the big artery that comes out of the heart that the heart's pumping into. So all the branches that go to all the vital structures are coming off the aorta. Mm-hmm. By the time it gets to the belly, the abdomen, it bifurcates right about the belly button level, and then the rest of it goes to the legs. Mm-hmm. So between that bifurcation and the takeoff of the kidney arteries is where we see in a lot of people this area start to get thinned out and start ballooning out.
And why is that?
Well, this is hereditary in about maybe 7 to 10% of the population.
Okay.
But that doesn't mean just because you have a parent that you're going to get one, and it also doesn't mean that if you don't have a parent, you won't get one.
Okay.
The most common cause of this is, again, atherosclerosis, lifestyles, smoking, especially smoking history. Mm-hmm. And
if we take nothing away from this show today, guess what we've taken away? Eat healthy and move, right? Move. Lifestyle.
Oh, move. No, eat right.
Eat right. Okay, fine.
These are all inflammatory problems that are happening within the circulatory system.
Okay, eat right.
But moving, you're going to burn calories, so that's good too.
That's good too. See? Right. So that's not so bad then. And then what happens with an aortic aneurysm?
Well, as this gets bigger and bigger, the walls get thinner and thinner.
Okay.
And they tend then to rupture once they get around 5 centimeters in width, which is about maybe 1.5 inches.
Okay.
From that point on, as they grow, they get bigger and bigger, and when they do, there's a tendency to rupture. Only 80% of the people who have a ruptured abdominal aortic aneurysm survive.
Oh, really?
It's got a high mortality rate, obviously.
Bleeding. The screening, what are you doing to the patient at that time? Are you feeling for something, or?
Well,
is that a bad question?
No. What we're doing is palpating the abdomen, because these things are pulsating like a heart in your abdomen. So if you feel a pulsating mass in somebody's abdomen, the first thing we need to think of is, do they have an aneurysm? Mm-hmm. And if that's the case, if we palpate that at the screening, we'll do an ultrasound examination right away to see if that diagnosis is correct. And if it is, then we need to do the full workup.
And again, going back to my usual question is, who needs to get this screening right away, or who is more prone to this? Does it follow any race, any gender, any age, any?
Mainly men. Men who are smokers, people who, either sex, who've had parents with an aneurysm, or a brother or sister, any sibling, any close relative, not a cousin, not anybody distant,
right,
but immediate family who has an aneurysm. There's a tendency of 7 to 10% to have one yourself. And like I said, smokers.
Okay. Dr. Castle, if I have a tendency to have an enlarged aorta like this, would it then make sense that I might be more prone to have plaque in the carotid artery, or is there a correlation?
No, not really. Not with an aneurysm, but if you have, let's say you have blockage in your leg arteries, then there's a higher chance you might have blockage in your neck arteries, because obviously you have vascular inflammation going on. Is it also causing a problem elsewhere? Okay.
Well, that leads us to the peripheral artery system. Can we talk a bit about that?
That's what we are talking about.
Yes, but I'm sorry. The peripheral,
the
lower. Yeah, that's what we are. Oh, we are the lower extremities.
The lower extremities, it's more benign because it takes longer for things to develop, and people usually get symptomatic not by having a stroke or a heart attack or a rupture. It's more like when they walk a distance, their calf muscles will start cramping up and they have to stop.
Okay.
And that's the reason is that there's a supply and demand problem, because you've got blockages in these arteries. You're doing fine walking around the house or lying in bed or a sofa or something like that, but if you go out for a walk and you find after about a block your calf muscles start aching and you can't walk anymore until you rest a few minutes, then that's an indication you have blocked arteries for your legs.
Very interesting. We've talked a lot about the symptoms and what we can expect from the screenings. Let's talk, if we can, a bit about treatment options. If it is discovered during some of these routine screenings that there is a possibility of some of these things, what's the next step? What are the recommendations?
Well, for the carotid arteries, we've got to get the plaque cleared. We got to get that artery open. So there's good flow going through. There's no chance for any embolization anymore or obstruction of blood flow. As far as the aneurysm of the abdominal aorta goes, once it becomes around 4.5 or 5 centimeters in width, then we're talking about we need to do a repair of this aorta, so we beat it before it ruptures. Put something in here that's going to stabilize that aorta and take the pressure off this sac.
And then for the lower extremities?
It's maybe stents, maybe a bypass graft, maybe nothing, maybe it's just medications depending on what degree. The legs do very well with collateral blood flow, meaning developing extra circulation around the blockages. It's very good about that. And so even though you may have total occlusion of your arteries, if you're not that symptomatic and you can live with it, there's no reason to do anything.
We're talking about the screenings. Once I get screening, you say, I'm just not sure, I'm feeling something that may be a bit abnormal. What can a patient expect then? What is sort of the procedure that happens? Do they
if we find something at the screening? Well, the screening, as we talked about, is just to screen for these things, not to totally evaluate. In other words, do you have a high chance of having these things, and we find that there's a strong possibility or probability that one of these problems are happening, then we need to do the full study. So so we know exactly what the extent of the problem is and how to treat it.
You know, I know this is not an easy subject to really talk about and conceptualize, but it's always wonderful to talk with you, because I think you do make us able to better understand the significance of getting some of these screenings. So we appreciate your time. We appreciate your time for joining us here on Healthy Living. Thanks. Have a great week. Bye-bye.